Hello, my name is Sonia DeWalt. I am a DSW candidate in the Doctor of Social Work program at Delaware State University. Today, I will be presenting my capstone project, Birth and Justice, Developing a Culturally Responsive Black Maternal Health Practice Toolkit for Obstetric Physicians. I'll be walking you through the toolkit's overall format and then taking a deeper dive into two of its 8 modules. That will be Module 1, which is the structured self-assessment, and Module 4, the accountability and evaluation framework, as an example of how the toolkit moves from individual reflection to individual change, institutional change. I want to begin with the numbers that has motivated this project. Black women in the United States are 2 to 3 times more likely to die from pregnancy-related causes versus their white counterparts, a disparity that persists across income levels, environmental levels, and educational levels. According to the CDC, 84% of these deaths are considered preventable. And critically, the leading driver identified in the literature is not biology. It is structural racism embedded in clinical training, institutional culture, and everyday points of care. This is the starting premises of my entire capstone. If the cause is structural, the intervention has to be structural too, not just an awareness campaign. The Birth and Justice Toolkit is an 8-module applied practice innovation design for obstetric physician. It gives clinical tools, a reflective framework, and structural accountability mechanism to deliver equitable, dignified, affirming care to Black women. The toolkit is grounded in 4 theoretical frameworks: the Pride framework, reproductive justice, critical race theory, and intersectionality. Together, these frameworks shape both the diagnostic lens and the intervention design. The purpose is deliberately narrowed and actionable to interpret the specific clinical behaviors, the institutional patterns, and the structural condition most strongly implicated in preventing Black maternal mortality at the actual point of care, not just the theory or policy. The toolkit is organized into 8 modules, moving from individual reflection towards institutional embeddedness. Structural self-assessment, anti-racist communication protocol, reflective clinical vignettes, the accountability and evaluation framework, pain recognition and equitable assessment, informed consent and shared decision-making, crisis recognition, and escalation of care, along with community partnership and doula integrations. I'm going to just focus on 2 of these modules, Module 1 and Module 4, because together they illustrate the toolkit's core logic: individual behavior, accounting paired with institutional accountability. I choose these 2 modules deliberately. Module 1 is the foundation. Equitable work cannot begin anywhere other than inside the clinician's own behavior. as Module 1 creates the mechanism for honest behavioral accounting before any other module can be meaningfully applied. Module 4 is the architecture. Individual learning without measurements produces intention without change. So Module 4 transforms personal accountability into institutional accountability, making equity audible, sustained, structural, and embedded. Together, they represent the toolkit's full arc, from individual physician's reflection to the institution obligation to measure and sustain that change. Let's begin with Module 1, which is the structured self-assessment, which is named Empower, Bias, and Institutional Patterns. This module sits within the power domain of the Pride framework and draws on pride, critical race theory, cultural humility as a theoretical grounding. Module 1 rests on a single foundation premise. You cannot produce equitable clinical outcomes through awareness alone. Equity requires behavioral accounting, not what you believe, but what you actually can do at the point of care. This module is grounded in the power domain of the Pride framework, which recognizes that the clinical authority physicians hold is not neutral. It is shaped by training, institutional cultures, and racial assumptions embedded in both. This premise is supported in the literature. The first practical tool in Module 1 is the Personal Bias Inventory. It asks the physician to self-assess across 4 domains: clinical decision-making and pain management, communication and patient engagement, consent and shared decision-making, and escalation and crisis response. An example reads, I apply equivalent escalation urgency to Black patients. Symptoms reported as I do with all patients, rated on a 5-point scale from never to always. The intent isn't to shame or diagnose an individual physician. It's to generate an honest structural baseline that the physician can return to and track over time. The second tool is the monthly accountability review log, and this is the feature that transformed Module 1 from the one-time training event into a sustained professional practice. It follows a simple 3-step cycle. First, reflect. Identify one encounter where racial bias may have influenced your decision-making, communication, or respond. Second, document. Track domain by domain progress across clinical decision-making, communication, consent, escalation, and institutional patterns. Third, commit. Name one specific, observable action you committed to in the coming months to advance equity in your practice. The design principle is simply monthly documented, specific, and sustainable. This is what closes the loop between reflection and behavioral change. Now let me take you inside Module 4. Now the accountability and evaluation framework measuring what matters beyond awareness. This module draws on the equity and disparity domains of pride along with implementation science and quality improvement systems. If you cannot measure it, you cannot sustain it. And if you cannot sustain it, a training becomes just a certificate becomes a line on a form, and Black maternal patient experiences no change in their care. The typical Module 4 exists because of a specific gap in the existing training in healthcare. There is no mechanism for determining whether anything actually changed. The typical pattern looks like this. A physician completes a training, their yearly training. They receive a completion of training or certificate. They return to bedside. Nothing is ever measured. Nothing is sustained, and Black women experience no change in their case. Module 4 closes that gap in 3 ways. It embeds equity measurements directly into existing quality improvement reporting systems. It creates documented and audible recorded whether the institutional have done what they committed to doing, and it transforms individual learning into institutional accountability. Module 4 is the Equity Metric Dashboard, built around 3 sections: by patient's race and embedded in existing quality infrastructures, clinical outcome metrics, including maternal mortality rate, severe morbidity rate, cesarean delivery rate, hemorrhage response, the hypertensive emergency response, and postpartum readmission rate. The process metric tracks things like time for pain report to management, time from symptom report to escalation, epidural offer rates, interpreter services utilization, and doula accommodation rate. And patient reported experience captures whether the patient felt their pain was taken seriously, felt respected by their care team, had a real choice in their care, and felt safe in the facility, drawing from the literature. The second tool in the QI integrated checklist is a 10-item audit tool that names accountability by assigning equity responsibly to specific people in specific roles. If asked, is maternal outcome data by patient's race in all QI reports or equity metrics included in the departmental quality improvement dashboard, or racial disparities process measured review at monthly QI meetings? Is patient reported experience data collected by race and reviewed quarterly, or quality metrics incorporated into peer reviewed criteria and individual provider performance reviews? And critically, is there a named institutional equity lead accountable for data dashboard monitoring? That last item matters the most. Without a named person responsible, accountability tends to diffuse and disappear. Bringing this together, Module 1 provides a personal bias inventory monthly accountability log, establishing a behavior baseline and individual accountability. That foundation builds directly into Module 4, which provides the Equity Matrix Dashboard and QI integration checklist, layering in patient reported experience data and institutional accountability. This is the toolkit's core design logic. Individual reflection alone is insufficient. Institutional measurements without individual behavior change is hollow. The toolkit is built to hold both simultaneously. I want to close with the words that motivated this entire project. Black women deserve to give birth without fear. They deserve to have their pain taken seriously, their knowledge respected, their autonomy honored, and their lives protected by systems that are supposed to serve them. They deserve, in the fullest sense of that word, to birth in justice. Thank you.